Good evening. Welcome back this week, our Wednesday weekly webinar. I did intentionally start a couple of minutes late because I still had some feedback from people saying that there's a bit of a lag time between them joining the webinar and actually getting in. So I thought I'd give it a little bit of time so that everybody could join. I hope everybody's had a good week and that things are coming sort of relatively back to normal and everybody's doing well. Today's webinar is about post-operative care, something that's quite often overlooked, but the reason I think it's very important is because this is the basis of which you want to maintain your good relationship with your patients. It doesn't matter how good a relationship you've created, if patients feel that you're not giving an optimal level of duty of care, all of that falls down. It's also an opportunity for you to really enhance that relationship too. And it's a good idea to have a look at what your patient journey is for each patient. It's one of the things I often advise people starting in practice to really have an in-depth look at, because things like that will get you a lot of new patients by word of mouth. It also provides a really high level service and makes it far more of a caring environment for your patients, which ultimately will bring dentists joy in doing, because that's ultimately why we're here. But there is the business aspect of it as well, and it's not bad for business, making sure you have good post-operative care and things happening from there. Okay. So without further ado, let's get started. I'm just going to start our webinar. Okay, as I try and say every week, we're building a community, and the community is based on your participation. It is important. So please do follow us on Facebook and like and share us, as the same for Instagram. It helps us to build a bigger community. The more people there are watching, just even as a basic, if you just share this, which takes you a couple of minutes, a new webinar coming up or our Education Institute, it means we can keep these webinars ongoing because there is interest and good interest. And then we can also cover particular topics that you want to discuss. I'm happy to do Q&As and everything else that you would like to do. The Implant Bootcamp, as I've discussed before, that's coming up the first weekend of February. And please get yourself involved. If you're a novice, then it's ideal for you to introduce implants into your surgery. And if you're not a novice, I have a few of my MSc students attending, simply because it's a recap, and what they're doing, because the cost is so low, is that they're bringing staff members. Because if you want your staff members to be able to set up and to be able to hand you things, so that you're not constantly asking for things, and for it to flow very neatly clinically, then your nurse or your receptionist or even your practice manager needs to know what you're doing and why you're doing it. And this is a great way of learning. It's not just for dentists. So bring your team. The registration is also open for the university certificate, diploma and MSc. Again, this is part-time, so you don't have to spend time out of practice. It's very little per year. I think it's about 12 days out of practice other than treating patients, and that's for the applied learning. And it's modular, so you don't have to do the whole thing. You can just finish at the certificate, which is a year part-time, the diploma, 2 years part-time, and if you want to go into the third year and do the MSc, then good for you. That go ahead and do that. So it is open. So please, if you would like to know more about this, you can. I'm happy for you to contact me directly. Either give us a ring or send us an email. You have the email there at the bottom of your page, education@drbobbychhoker.com.au, and you have our telephone number. And come and see us. Even if you're just interested, you're not interested in the courses, it doesn't matter. If you want to come and have a look at, if implants are for you, or if you're placing implants, you know, what you could learn. Maybe you might impart something onto me, you know, something that I don't know about. Come and meet us, you know, we're welcoming. You might want to learn about some systems. Maybe you've started a practice, you want to learn about how to market the practice, how, you know, you get to a stage where we're at with our practice, and we're happy to share that with you. The Facebook is at Bobby Chhoker Education, and the same for the Instagram. Okay, let's get started. So, post-operative care. As I said, it's important, and the reason it's important is because we really want to make sure our patients don't have complications, they're not in pain, comfort for the patient, but also we don't want those complications that we could nip in the bud to suddenly turn into something that's going to be very difficult. So I'm just going to move this down. So if we deal with them early, they're much easier to deal with. As I've said before, try and do things very safely. If you do things that have lower risk factors, imagine you're walking on a wide road. If you get one or two things that go wrong, the road gets narrower, but it's still manageable. If you're trying to pile everything on top of each other and the risk is accumulated, then you're pretty much walking on a tightrope, and even one thing goes wrong, you fall off. I give you an example, you know, if you had a tooth with bone loss, it's got infection, it's got a high smile line. That we've been through this, and we'll be definitely going through this in great detail at the boot camp, because we'll be taking live cases and going through them, or my cases, sorry, that we'll be going through step by steps with things I've taught you. If you're going to remove the tooth, clean out the socket, graft, place the implant at the same time, as well as immediately load, you're in a situation where, if you don't know, even in those cases, you know, I don't do that very often, but if I do, there's a number of criteria I go through for each one of those decisions. And it's important for us to be able to deal with things and nip them in the bud. Okay, so the visit should take 7 to 10 days after the implant surgery. I usually prefer about 14 days. Okay, because there's not usually much going on, 7 to 10 days. The same to deal with things early, 10 to 12, 14 days is not going to make a huge difference. And trust me, if there's something happening and going wrong, your patient will tell you very quickly. If you've got good post-operative care sheet, and I'll just show you a bit of ours, you know, we have several. I think I've got the implant and the bone grafting one for you, to a little bit of it we could discuss and show you. They know what to look out for. It's always fear of the unknown. So if you have a well-informed patient, they'll know, oh, Dr. Bobby Chhoker has told me that that may happen, and this is what I do if it occurs. I've read my sheets on there. If it's a surprise and they don't know what to do or how to manage it at home, that's when you get patients that are angry or irate. And if they're not, they'll want you to immediately see them or contact them, not knowing the difference between urgent treatment and emergency. And it takes up your time and resources. So, you know, it's good even in that way. It depends on the patient. Any complications during or after surgery, a second follow-up visit may be required in another 3 weeks. That is important. We tend to do that more if we see something that, you know, we really need to keep an eye on. Review with the patient whether his or her normal oral hygiene procedures can be resumed. Toothbrushing directly on the surgical site should have been discouraged at the last visit in order not to disturb the healing site after surgery. This is fairly obvious. However, you want to keep the area clean. Okay, so quite often you can use alternatives like a manual brush or a softer brush, not soft, softer, and to keep in the adjacent teeth, because one of the things we don't want is either is a bacterial load. Check the patient has maintained adequate plaque control, as I said, by using regular antiseptic mouth rinse during the first 2 weeks after surgery. I like them to use an antibacterial regular mouthwash for their morning and night cleaning, and in between, depending on the surgery and the circumstances, I will usually ask them to do one of two things. I usually get them to do a Savacol rinse, a chlorhexidine gluconate rinse, after lunch and after dinner, not whilst brushing, because you don't really want fluoride interaction with that. You don't want, you want the maximum effect it can give. And in certain cases, I will also or ask them to have hot salt water mouthwashes. And as we all know, it's not salt, that's just osmotic potential. It's heat energy, and that's basically accelerating the healing in the area. Know how to assess the healing site, be able to recognize and treat compromised wound healing situations, know what to do in the case of post-operative complications. These are steps that you should perform during the visit. Assessment of the healing surgical site, well, that's fairly obvious, you want to have a look. So suture removal and oral hygiene instructions, handling of complications if necessary. Okay, let's go into the next part. Okay. Assessment of the healing surgical site. Okay, obtain the patient's feedback on any symptoms experienced during the post-operative and healing period. This is important, and quite often we miss this. I do this all the time. I miss it sometimes where I've forgotten to ask the patient, and the patient is your best source of information. They may have been feeling something the first 7 or 8 days. That's important for us to glean that information and act on it, and it may have disappeared at day 8, 9, 10, but it's important to have a history or a record of that, because otherwise we don't know what's occurred. Ask a patient about any symptoms. Examining the patient. Examining and assess the healing surgical site and the peri-implant soft tissues and check for signs of 1, infection. Okay. It doesn't always have to just have an exudate, but patients usually know when it's infected because it smells. You'll know because it smells, before they've actually sat down and opened their mouth. You'll know about it. And they will probably have pain associated. Most infections, when it's infected, it tends to be quite a lot more painful than the norm, and usually with experience you can tell the difference. We will talk about bleeding and swelling as well a bit later. Dehiscence tissue, if the tissue comes apart and there's an opening, it depends on what the procedure we've done and what we've performed. In most of those cases, if it's implant placement, it's not been affected. And the cleaning site out, we would then try to basically reoppose the tissue. Nerve paresthesia, record any altered sensation or loss of sensation reported by the patient. Sometimes this can just occur at the beginning because of swelling. If you plan properly and you have right surgical skills, there are certain safety systems that we have for just about all parts of the mouth when you're placing implants that should prevent you from causing nerve damage. Occasionally, for example, above the ID nerve, if we're getting quite close to it, and you are putting the implant in, the pressure of the implant can push on the apical bone at the apex of the implant and above the ID nerve and cause a level of compression. This manifests again as altered sensation. The good thing to do here, as we've discussed, I think probably in the last seminar or maybe one before, is that it's a good idea to map this and take a photograph. And what I mean by that is take not a sharp instrument, something that they can feel, and mark onto the face until they can't feel it, and put a pen dot or a marker dot there, something that you can take off afterwards, preferably. And you go around until you create a map of the area where they have numbness or altered sensation. You then want to bring them back and do that again, because when you do that again, you can then see whether that area compared to the first time has become smaller or larger, or may have stayed the same. In most cases, if that altered sensation area starts to decrease in the first 3 months, you'll find in most cases it will completely dissipate and disappear, and they get sensation back. In a few cases you may find they still have small amounts of dysesthesia and altered sensation. If there is no change whatsoever, or it's getting worse, it's likely there is nerve damage. In those cases, you want to obviously when they come back for a review, you want to take an X-ray. If you don't have CBCT, you can still use Parallax to try and take one. Ideally, I would suggest you invest in a CBCT. I won't do an implant without one. And if you don't have one, then refer it locally to get the CBCT so you can have a look at it properly. There's nothing, it's not great for it to have happened, but it's much worse if you don't manage it well and you don't take the necessary steps to investigate it. What you don't want to do is leave it 3 months and find out you've basically gone into a nerve and done nothing about it. Not saying that referring it then to Max Factor and removing the implant will reverse the situation, but it's important for you to manage it. Okay. So usually with suture removal, your local anesthesia isn't usually required. I rarely have to give it. Sometimes I have to use it when I'm using particular sutures, PTFE or glycon, because the tissue tends to sort of grow around them and sort of almost envelope them. And trying to get those up so you can remove them can sometimes be difficult, especially when you're using very fine sutures. In those situations, I do use resorbable in almost every case other than the PTFE. However, patient is complaining that they don't want them there, especially something like glycon can be sort of quite prickly, like, a very thick, bristly beard, if you've got one, or that type of thing. And it annoys patients, so they want it removed. So sometimes, you need to give local. If necessary, you give topical anesthesia, gel. Clean neighboring teeth gently with scala or cotton pellet. That is important. You will find build up around a surgical site. Identify the sutures, gently lift each suture from the wound with forceps and cut with scissors. The reason that you do this is if you do interrupted sutures, you can see the loop that you've created, and then it's very easy just to cut that and take the suture away. Rinse the area thoroughly with saline or chlorhexidine solution. Chlorhexidine is preferable. Assess the wound closure again. Reinforce oral hygiene instructions with the patient. It's important after suture removal that they maintain oral hygiene, because a number of complications can occur between your review and seeing them again. And that's why sometimes it's recommended you see them for a second review. Check that all the sutures have been accounted for and removed. In the last visit, you should have documented how many sutures were placed after surgery. In case you see tissue dehiscence, prescribe a local disinfectant such as chlorhexidine gel to be applied twice a day by the patient, and review the patient again after 1 week, your recept or whatever you want to use. If we've got resorbable sutures and you're not using silk, and you use silk or non-resorbable PTFE, then we do note how many sutures we've placed. Quite often with a lot of these, we're taking photographs, so that also helps us. If it's resorbable, I tend not to, because they will resorb. And sometimes when they come back, if I can't get the suture, the patient doesn't want the site disturbed, and it's only just, they may have had pain, and now they no longer have pain and don't want you disturbing the site, then we leave the sutures to resorb themselves. In those cases, I would definitely bring the patient back again a few weeks later and check again to see that everything is good. Okay, implant-specific complications include implant loss, infections, recurring inflammation, damage to neighboring teeth, damage to nerves, perforation of the maxillary sinus or nasal cavity, maxillary sinusitis, and fracture of the mandible. Okay. With implant surgery, some of this information, thank you very much, has been basically kindly donated by Straumann. So we're going through some of their stuff. But one of the main things that you tend to see, and I tend to see with a lot of grafting, is tissue dehiscence. So the post-operative care with this is the fact that, if you've had a graft, which we're going to go through in a moment, the post-operative care instructions, the reason I'm going through complications associated with it, with the post-op, so that you know what to do. You want to irrigate thoroughly with chlorhexidine and any topical chlorhexidine gel or spray. The patient can use this. The gel is usually, I find most patients find it very easy to use a gel, and I give them a bag of cotton wool rolls, so they put a bit on and I show them how to put that on, and that's the best way to do that. And you want to review the patient again after a week. Where we've used membranes, the post-op care, is to use the sort of soft toothbrush and make sure that they're cleaning, and I like hot salt with the mouthwashes in that situation. If they do have mouthwashes, I don't want them squishing and spitting. They're just bathing the area, opening and letting the liquid dribble out. Okay. Bleeding and hematoma formation can be a consequence of any surgery, and that's true. We've had patients where we've done very little and had bruising and large hematoma, and other patients where we've done, a full mouth rehabilitation, we've done alveolectomy, we've done some grafting, we've removed some impacted teeth, we've done bilateral sinus lifts and simultaneous placement, and there's nothing. Okay. Secondary bleeding can be caused by deficient vasoconstriction, damaged blood vessels, systemic bleeding tendencies, or use of anticoagulants. If the patient's using anticoagulants, quite often when we do these cases, then what we usually need to do is we ask the patient, with the permission of the GP, to stop anticoagulant therapy or give them an alternative, which means in your post-surgical and your post-op care, you need to remember, even though the patient's responsibility, it's also yours, that they restart their anticoagulants. In order to reduce the risk of post-operative bleeding, hemostasis must be achieved at the end of surgery before discharging the patient from your practice. The patient must be given clear post-operative instructions, including the use of appropriate pressure with a gauze, avoidance of sports and other strenuous physical activity for at least 3 days after surgery. Not in our practice. I stress to patients, if they've had an implant, that they abstain from any form of sport or a strenuous physical activity for 2 weeks. And if it's a graft or a sinus lift, 3 to 4 weeks. There's nothing wrong with them just abstaining that bit longer. It may be inconvenient. There's everything wrong with everything going wrong and falling apart. And then guess who has to pick up the mess and pretty much gets it in the neck? You will. Okay, as do I. With hemostasis, this is really important. You need the number of cases that we get sort of hematomas, and I'll go into sort of full mouth rehabilitation or large bone grafts in a moment, is mainly because there's been secondary bleeding. And there should be, because of deficient vasoconstriction, I liken a lot of the grafting cases also to keep the patient comfortable, to use a slow release, long acting anesthetic, so we maintain vasoconstriction. If we find that there is bleeding during the surgery and that we can't stop the bleeding, or spontaneously bleeding, there are a few reasons. One, normally applying really good pressure for a period of time usually gets rid of that. And other times what happens is that if that doesn't get rid of that, you can use a few other things. One, in those cases where it's continuing bleeding, I will usually open the site up again on the day, after we've completed surgery. And sometimes that's a pain. So it's usually a good idea to look out for bleeds, before you actually stitch up. If it's within the tissue, you can do a few things. One, you can either find the blood vessel, loop around it, and suture it, okay, which is a skill in itself. You can cauterize it using a laser or heat, and in some cases in surgery now also have cryo, so you can use that too. One of the other main ways where we have larger bleeds, which are osseous bleeds, where we have a intraosseous blood vessel, and you'll know it because it's actually squirting. We have them sometimes with large procedures squirting across the room, and that's not that uncommon. And to stop those, you can't really get to, because usually it's down the rabbit hole, and you can't get down to it to actually get to the area of it. With those cases, if it's towards the surface, you can cauterize at that surface. You need to be careful of burning bone. But one of the main ways we use is tranexamic acid. So, you can get that in a preparation that you just probably would need to go and see a compound pharmacy for. And we have that at hand that we use during surgery, so we can stop these situations. So post-operatively, if the patient, obviously they don't have all of this at hand, But if you're doing this, your post-operative complications are, period is likely to be less eventful. So it's important to do that. But while they're at home, the main things they can use is really pressure. Okay, so you're not going to give them anything beyond that. And making sure that they have some sterile gauze and they apply firm pressure is important. And they just want to apply firm pressure, keep looking at it. You need to tell them that they apply really firm pressure, as firm as they can, and do that for at least half an hour before they have a look. Now, it'll be bloody, but make sure it's not oozing or running blood as if they've cut themselves. This is what I say to them. I will then ask them to use the same bit of gauze that they used a moment that they had for half an hour in their mouth, back in the site, no matter how messy it looks. Obviously, if it just can't be held because it's a complete large hematoma around it, that's just basically a large clot, then obviously not. But if it's not that situation, then the reason I asked them to do that and not put a fresh bit of gauze is because the gauze contains clotting factors, and if you put a fresh bit of gauze in, they have to start all over again. So it's not always the best idea. Okay. If hemostasis is not achieved as expected after surgery, continue to monitor the patient closely while the patient is applying pressure with gauze on the surgical site. So need to make sure, and you record in your notes for extractions, bone grafts, implants, anything surgical, hemostasis observed. Okay, as well as noting that you've given post-operative instructions. Try to identify cause of bleeding related to surrounding anatomical structures, as I've just discussed. You can inject local anesthetic with the vagus into the area, and as I said, we use a slow-acting, long-acting, slow release, one on top of our local anesthesia we use for the actual procedure. Additional sutures for tighter wound closure. Okay, that's a good way of doing it. If you're in that situation, it's probably better to use Lycra. You get more tension with it than Vicryl. Okay. If breathing is uncontrolled, appears to be pulsating, call the emergency services immediately. Now, if you've done what I've asked you to do and you've got the necessary equipment and medications to deal with these situations, surgery as you should do, otherwise you shouldn't be doing surgery, then you wouldn't really have to do that. It's only cases where you've got a severe bleed, and I don't understand why you would have one. If you're doing simple implants, there are certain cases, the most obvious being the lingual artery, and that does occur, and that usually doesn't end in uncontrolled bleeding. It causes large swelling of the tongue, so it's an internal bleed, and the main problem there is asphyxiation of the patient. So in those cases, you have to grab gauze and almost you pull their tongue forward out of their mouth, so the back isn't swelling up and restricting their breathing. In those cases, yes, you touch wood. I haven't been there, and God willing, I won't go there, and nor do any of you. But you should know what to do. Okay. As I said, Straman had provided these slides for us and some of the information here. I think it's a good sort of summation of post-op stuff, but that's why I'm presenting it to you. This is healing phase. This is important. And they've got it here as SLA active and this SLA. The SLA active implants, the surface integrates, at a faster rate. I exclusively use for my patients Straman implants because that's what I enjoy using, and they're the implants of choice for me. There are other implants out there. The critical period of osseointegration is the first 2 to 4 weeks after surgery. Primary stability of bone achieved at the time of implant placement changes to secondary stability. As new bone is deposited, this process of osseointegration is shown in the following graph, depending on the type of surface of the implant. So you can see in the first curve, the primary stability declining, and that lovely stability you got at the beginning, being all important, as we all know, it's probably the number one thing I look for, within reason, is primary stability, because that gives us, it's the key factor in getting osseointegration. That declines in up to about 2 to 4 weeks, as said, and at the same time you get secondary stability from new bone. So the total stability is affected. So the critical period of osseointegration is the first 2 to 4 weeks after implantation. as discussed, it goes from primary to secondary, and you see why this is important. The dentist should be aware of the total stability dip can occur at about 2 weeks, okay, for the SLA active, and about 4 weeks for the SLA. Avoid a manipulation of the healing cap or healing abutment during this time to allow for the implant and bone to osseointegrate. The implant's total stability is the weakest at the point of the stability dip. If the healing cap or healing abutment is loose, only use very gentle hand tightening, okay? If you've had one decision where it's loosened, and it happens to everybody, sometimes trying to use the shortest healing abutment that you can use, obviously making sure it's supragingival and it's not, absorbed by the gingiva, is recommended. It's not essentially out of occlusion, because if you put a bolus in the mouth and you bite onto it, even a cover screw exposed will be an occlusion, but it's reducing the forces. So as I said, 2 weeks for the SLA active and 4 weeks for the SLA. And it's to avoid unnecessary manipulation. So depending on the type of bone of implant used and the quality of bone, the guidelines for the healing phase osseointegration, there's a chart here where they summarize them. This is for the SLA active, the SLA. It's got good bone quality and adequate bone quantity. Implants with diameters of 4.1 up, and an SLA or SLA active with a minimum length of 8 millimeters. For the SLA active, it's 3 to 4 weeks, and for the SLA, it's at least 6 weeks. For poorer quality bone and narrow diameter implants with a shorter length, the SLA active, it's at least 8 weeks, and for the SLA, it's 12 weeks. So you must know and wait for the recommended healing phase to be completed to achieve osseointegration. That's important. In general, it is recommended to wait at least 6 to 8 weeks before seeing the patient to take impressions for final restoration. I recommend that you change that to 12 weeks. There's nothing wrong with waiting. There's everything wrong with rushing it. And if you rush it for the sake of a few weeks and then it all falls down, you have to explain to the patient why, and you have to fix the problem and start again. And you really don't want to be in that situation. Before we get into the last slide, bear with me, I am going to share with you the post-op instructions that we give. Well, I'm going to share some of them with you so you can see what they are like. You can see what we give to patients at the end. I'll just briefly go through them because I don't want to go through the entire sheet for long periods of time. I want to try, although some of our webinars were longer at the beginning, I want to try and keep these so that you have short webinars with plenty of information and you're not trying to remember vast amounts of information. So let's have a look. If we go here, well, not that one in particular. For example, after bone grafting, some of the things that we've put in there: do not disturb the touch wound, avoid rinsing rigidly or spitting 2 days to allow blood clot and graft material for stabilization. And we put at the top, this is typical of a bone graft, so they know, and especially things like small particles become dislodged or worried about swallowing them. They're biocompatible. They pretty much pass through their system. You should not have any significant amount of blood in your mouth. Saliva can be swallowed, even if slightly blood tinged. In a lot of cases, what patients will do, you have to remind them that, look, it's not bleeding. If you open it, you can see it bleeding, that's bleeding. But if you're getting blood in your saliva, it's usually because it's mixing saliva and looks like more than it is, but it shouldn't continually do that for, ongoing afterwards. What they don't want to do, and they have a tendency to do this, is try and mop it up and suck in the area of the site. And that's not a great thing to do because they're just basically triggering the bleeding again. Keeping your mouth clean after surgery, fairly important. Do not apply pressure with your tongue or fingers in the grafted area as the material might be moving initially. Okay. Do not constantly pull your lip to have a look at the sutures. You can cause damage because what's happened, especially, for example, let's say an anterior where we've had to, for example, do a bone graft. and we've taken a buccal flap and we periodically relieved it and wrapped that over the ridge, the tension, or we want the tension-free flap and sutures, but it's connected. The area is shorter, so then pulling up and having a look can cause these problems. Don't eat boiling or hot foods or drink for a few days. What we mean by there's not drink for a few days, but not have hot drinks and things. And the reasons for a few days is you're saying, well, the anesthetic's worn off. Why? In a number of cases, the anesthetic worn off, but the inflammation of the area, particularly bone grafts, where we're bone harvesting in the area, cause the area to be numb for a few days afterwards. It's totally normal, largely due to the inflammation. So, you would almost want to treat it as if they are numb. Do not brush your teeth in the area of surgery for 48 hours. When brushing, be very gentle. This is for certain, bone grafting procedures. Quite often, this is sort of double the fact that they are using a mouthwash and want to keep the area clean. It's a balance. We may prescribe antibiotic rinse. Okay. Chlorhexidine, Peridex, Periogard. For certain procedures, the rinse should be used at least in the morning and at bedtime for routine mouth care. Ideally, they want to use it after meals or swap it around. They can brush off in the evening and then have it at bedtime just before they go to bed, depending on when they brush their teeth. Do not eat, drink, or rinse the mouth after using medicated rinse for at least 30 minutes. We want to have its topical effect, but to be honest, if you're using Savicol, everything else tastes awful after that. Do not smoke. It is possible for at least 2 weeks. Now, as I discussed before, my view on this is that you need to inform them. Ideally, you don't want them to have smoking, but you want to have them stop smoking for implant treatment. It's a good reason. It's your job to give them support and advice for cessation. In certain cases, not able to, they're massively reduced, and you need to make them aware of the risks. Do not exercise, do not do heavy work or lifting for 2 weeks or 3 weeks, depending on our other one for sinus lifts. The information sheet is a little bit different, so that it's as smooth as possible. And then there's got a bit on night guards and wearing dentures, what to do if there's bleeding. And that's pretty much our one for bone grafting. It does actually come with another information sheet as well. We'll be going over those again at the boot camp too, and we'll probably sort of distribute our templates for those so that people can use them. So, if you want to sort of get hands on them and learn about them properly with all the other sections, I've covered things briefly today. And then please sign up and come along, bring other colleagues, brings practice members, whoever you can. As I said, it's $595 for one person and it's $595 for two. That's 12 hours CPD, so it'll help your hygienist or your associate or your business partner or any other dentist keep their CPD as the deadlines close or get closer. I hope you've enjoyed the post-op instructions and complications webinar, and I look forward to seeing you next week. Take care until then. Bye-bye now.